Welcome to the Explainer. So today, we're going to be looking at a true biological marvel. I mean, this is something operating silently inside your chest every single second of your life. We are talking about the pleura.
I want you to think about this mechanical mystery for just a second. Your lungs expand and contract thousands upon thousands of times a day. Now, if you take two dry surfaces and rub them together that often, what happens? You get friction, you get heat, and eventually you're going to see severe tissue damage. So how exactly do your lungs constantly inflate against the hard, bony cage of your ribs without just completely wearing out? Well, the answer lies in a pretty elegant microscopic defense system.
Okay, let's dive into this. Here is our roadmap for today. First, we'll meet the pleural cavities. Then, we'll look at the two pleural layers, followed by the pleural recesses. After that, we're tackling nerve supply and referred pain. And finally, we'll look at what happens when things go wrong. All right, starting off with Section 1, meet the pleural cavities. So the ultimate secret to frictionless breathing is the pleura. By definition, the pleura is a serous membrane. It's lined by this flattened epithelium, which we call mesothelium, and its whole job is to secrete a watery, lubricating fluid. Picture this. During early embryonic life, the developing lungs actually push inward into a closed sac. Because of that inward push, what was once a single open space becomes a continuous double-layered sac that entirely wraps around each lung. And you'll notice the thoracic cavity isn't just one big open box in there, it is brilliantly divided. You've got the right and left lateral compartments. These are the actual pleural cavities housing the lungs, and separating them right down the middle is a mass of tissues and organs forming a mobile septum. We call this the mediastinum, and it's where the heart sits. This compartmentalization is absolutely crucial because it means if one lung gets compromised, the other one is securely isolated.
Moving right along to Section 2, the two pleural layers.
There's a really stark contrast between the inner and outer layers of our protective sac. They're almost like two completely different characters. The inner layer, the visceral pleura, is incredibly clingy. It wraps the surface of the lung completely, even dipping deep down into its fissures. You literally cannot separate it from the lung tissue. The outer layer, the parietal pleura, is thicker. It doesn't actually touch the lung itself. Instead, it lines the entire inner wall of the chest cavity.
And because that outer wall, the parietal layer, covers so much physical territory, anatomists divide it into 4 specific subdivisions, just based on what it's touching. So you have the Costal Pleura lining the ribs, the Diaphragmatic Pleura resting right on the diaphragm, and the Mediastinal Pleura facing inward toward the heart. But check out that last one, the Cervical Pleura. This is a dome that extends surprisingly high. We're talking about an inch above the medial end of your clavicle, reaching right up into the root of your neck. It's kind of wild to think lung tissue reaches up that high, right? Before we leave the chest wall altogether, we absolutely have to mention the endothoracic fascia. This is a thin layer of loose tissue that gently attaches the outer costal pleura to the ribcage. The reason this matters so much clinically is that because it's so loose, surgeons can very easily separate the pleura from the thoracic wall during operations. They can literally peel it away almost like damp wallpaper, and they can do it without tearing the delicate membrane itself. All right, Section 3. Pleural recesses, basically room to breathe. When you're just sitting there breathing normally, your lungs don't completely fill the pleural cavity. The body cleverly maintains these expanded reserve spaces where the two layers of parietal pleura actually touch each other, just waiting to be pushed apart. We call these pleural recesses. So when you go for a run or exercise and you need to take a massive gasp of air, your expanding lungs have somewhere to go. They slide perfectly right into these biological reserve tanks.
Now, there are two main recesses you need to know. First up is the Costodiaphragmatic Recess. This one is located at the very bottom of the chest cavity, roughly between the 8th and 10th ribs. Now, because of gravity, this inferior space is highly critical. If you have abnormal fluid in the chest, this is the very first place it's going to collect. Then we have the Costomediastinal Recess at the front of the chest. Interestingly, it's noticeably larger on the left side. Why? Because the body has to perfectly accommodate the heart pushing into that space, creating a little pocket we call the cardiac notch.
Okay, now I want you to consider a really strange clinical phenomenon. Let's say a patient comes in. They have an inflamed pleura deep inside their chest, but they are complaining about severe pain way up in their shoulder. So what's going on there? Why does inflammation in the chest cause pain in the shoulder? That brings us perfectly to Section 4, nerve supply and referred pain.
You see, our two pleural layers have completely different embryonic origins, and because of that, they have entirely different neurological wiring.
The inner visceral pleura develops from a deep embryonic layer, and it's supplied only by autonomic nerves. This makes it totally blind to pain. You absolutely cannot feel it. But the outer parietal pleura, that's wired with somatic nerves, making it exquisitely sensitive to any kind of pain.
So think about this central part of the diaphragmatic pleura, that highly sensitive outer layer resting right on the diaphragm. It gets its nerve supply from the phrenic nerve, which originates from spinal cord levels C3, C4, and C5. But guess what else is wired to C3, C4, and C5? The supraclavicular nerves. And those are the exact same nerves that supply the skin of your shoulder. So when the pleura on the diaphragm hurts, the brain gets totally confused by the shared wiring and projects that pain all the way up to your shoulder. It's a classic example of referred pain.
All right, finally, let's get into Section 5, when things go wrong.
When the pleura becomes inflamed, a condition we call pleurisy or pleuritis, which is often caused by nasty infections like tuberculosis, the frictionless bodyguard completely loses its lubrication. Inflammatory exudate starts to accumulate, making the surface really rough. So instead of gliding, those two layers are scraping together like sandpaper with every single breath you take. It is agonizingly painful. In fact, doctors can literally hear this harsh pleural rub just by placing a stethoscope on the chest wall.
Now, normally, the pleural cavity isn't actually an empty space. It's what we call a potential space, and it contains a microscopic film of fluid. But how much fluid exactly? Just 5 to 10 milliliters. That's practically nothing, but that tiny amount is all it takes to lubricate the entire surface of the lung. However, when things go wrong, excessive fluid can start to accumulate. We call this a pleural effusion. Remember those reserve spaces we talked about earlier? Well, the fluid floods right into the Costodiaphragmatic recess, obliterating that space and completely blunting the lung's ability to expand. To fix a massive effusion like that, doctors have to perform a thoracocentesis to actually drain the fluid out. Imagine the exact anatomical path that a doctor's needle has to travel. It goes through the skin, then the superficial fascia. It pierces the serratus anterior muscle, pushes right through the intercostal muscles between the ribs, cleanly pops through that loose endothoracic fascia we mentioned earlier, and finally, it pierces the parietal pleura to reach the fluid. It is honestly a masterclass in applied anatomy.
But, fluid isn't the only threat here. The accumulation of air is called a pneumothorax, and that breaks the vital vacuum keeping the lung inflated. This can be spontaneous, say from a ruptured blister on the lung, or it can be open, like from a chest wound that physically sucks air in from the outside atmosphere. But most terrifyingly, it can be a tension pneumothorax. That's where injured tissues act like a one-way valve. Air enters but cannot escape, building up this immense pressure that physically shoves the heart and the mediastinum clear to the opposite side of the chest. It's a rapid, absolute life-threatening emergency.
And honestly, all of this brings us to a pretty humbling realization about human anatomy. Your lungs are biological titans, right? Yet their daily, continuous function relies entirely on just a microscopic 5 milliliter film of fluid and an incredibly delicate vacuum seal. Just a few extra milliliters of fluid or a tiny little pocket of trapped air is enough to collapse the entire system. It really leaves you marveling at the delicate, high-stakes engineering happening inside you with every single breath you take. So, how well are you protecting your frictionless bodyguards? Thank you so much for joining me on this explainer. Keep learning and stay curious.